Well, good morning. Thank you all for showing up in the wee hours to this talk. Appreciate it. We're here today to talk about reversal agents, which has been an interest of mine across the last couple of decades. And I'm honored to be joined by Dr. Frank Peacock from Baylor College of Medicine. Thanks. Reversal of misfortune, managing uncontrolled factor Xa inhibitor bleeding, and some practical insights is the topic of the day. Wanted to thank PeerView and AstraZeneca for supporting this activity and setting it up here at ACEP 2023. If you haven't already, please complete the pre-event survey. Look for some additional polling. You've got these handy-dandy little input devices on your desktop there. And submit your questions also. We'll have a Q&A at the end, and look forward to discussing some of the ins and outs of this very complex area, right? It used to be pretty simple, just warfarin, vitamin K, plasma. That was all you needed to know. And now it's, of course, quite a bit more complex, and we'll get into it. So our objectives for today are to give you guidance on selecting the right reversal agents, teach you the difference between the dosing and the speed of reversal, and help you work on a team-based approach to providing these reversal agents at the bedside in order to achieve the best outcomes for our patients. This will all be online, so you can refer back to it. There'll be some downloadable practice aids that you can use to when you get to the bedside, because this is a pretty complex area of medicine now, and it's good to have a reference point to go back and review. So here's the first question. Just tell us who you are. Just indicate what your degree certification is. And tell us what your specialty is. Okay, and so how many patients do you individually reverse? And this includes all anticoagulants, right? So you probably still see a few warfarin cases, those who are on warfarin for mechanical valves or ventricular assist devices, and then the factor Xa, of course, far and away the largest group of anticoagulated people in the U.S., right? 7.5 million now, I think. And then a few people in the U.S. on dabigatran, but if you decide to practice in Germany or Japan, you might see some more, but not so much in the U.S. And what setting do you practice in? Academic, community, other? All right. And here's the first poll question. So, which one of the following patients might you have a special consideration for using the FDA-approved reversal agent for factor Xa inhibitors, andexanet alpha? A patient, 75 years old, fully anticoagulated with rivaroxaban with a deep ICH, a 15 cc hematoma volume, and a high stroke risk, CHA2DS2-VASc 9. Number two, a patient 80 years old, fully anticoagulated with apixaban with a ruptured AAA and in need of endovascular repair. Or a patient who's 78 years old and fully anticoagulated with apixaban with one of these wispy traumatic subarachnoids, some parenchymal contusion, and a recent PE. And it's always an out, right? There's always, I'm not sure, that's fine, but it's a cop-out. Don't cop out. And the second poll question is basically getting at what is a major bleed? So how severe would a bleeding event need to be for you to order a specific reversal agent for a DOAC-treated patient? major bleeding not controlled with supportive measure, bleeding into critical organs such as the brain, the spine, the eyeball, life-threatening, all of the above. You know, when those questions are on the board and all of the above is an option, it's almost always the answer, right? And specific reversal agents aren't available at my hospital. That's unfortunately all too common. And 6, the cop-out. We should have played the Jeopardy music during that. In your hospital's IC, poll question 3. In your hospital's ICH protocol, what is the goal for anticoagulation reversal after arrival in the ED? I have my own thoughts about this, but pick the time interval you think is a reasonable goal at your center, and you know, case by case, and I'm not sure similar answers. So poll question 4, woman is 78 years old on apixaban for prevention of thromboembolism, presents to the ED with a low impact head injury and a subdural. How will you treat her? So it's apixaban, a subdural, supportive measures, charcoal. I should say their last dose was 8 hours ago. Vitamin K, PCC, and Dexanet, idarucizumab, and I'm not sure. Okay. So we'll come back to those poll questions again. Hopefully we'll have given you a better grounding in the science to answer those questions here at the end. We'll first talk about identification and differentiation of DOAC reversal agents, indications, and mechanisms of action. And that's me, TJ Milling, from the University of Texas, Dell Medical School, Departments of Neurology and Surgery. So other than warfarin, the anticoagulants that we deal with the most are really apixaban and rivaroxaban, some edoxaban, betrixaban. It's kind of a weird one-off. It was actually made by the same company that made the reversal agent, Indexnet, but not broad adoption. Now, the current label for Indexnet, based on the Annexa 4 trial, only covers apixaban and rivaroxaban, but there is edoxaban data, and using Indexnet may technically be off-label for edoxaban or even betrixaban if you happen to catch one of those patients, but the mechanisms are the same, and the data is pretty robust for edoxaban anyway. Dabigatran, the lone direct thrombin inhibitor. The history of DTIs is kind of interesting in that, you know, the very first one that came out, zimalegatran, was actually pulled for liver toxicity, so dabigatran was formulated to be almost entirely renally cleared and was the first DOAC out. So we saw lots of bleeding on dabigatran for about 2 years, and then rivaroxaban and apixaban came out and very quickly sort of overwhelmed dabigatran here. But having been made by Boehringer Ingelheim, you still see a fair amount of dabigatran in Germany. So moving on. Then, of course, dabigatran has its own reversal agent, which is a monoclonal antibody, idarucizumab monoclonal antibody, as opposed to the factor approach, which was used for Indexanet and the reversal of the whole class of anti-TNA drugs. So the reason, I mean, when we trained, it was simple, right? We just had warfarin, the rat poison from the University of Wisconsin from the 19-teens, and the reversal agent. Plasma really didn't work, but we'd just gotten PCC approved in about 2013 when the problem changed, when we had all these, and frankly, you build a better mousetrap, they were better than warfarin, right? We saw so many warfarin bleeds, and we see a lot less with DOACs. But we didn't have a reversal agent, so it's like, what if they brought upon us? We finally got a warfarin reversal agent that worked, PCC, and then And then we suddenly had new anticoagulants. How do we reverse them? But it's easy sitting in the ER seeing the complications to forget just how beneficial these drugs are overall, and why 7.5 million people are now on factor Xa inhibitors in the US, because they're the best way to treat an ICH is never to get it. And these drugs are much more effective, are still effective in stroke prevention, as effective, but have much less ICH, which is the most feared anticoagulant complication. And the shorter half-lives and rapid onset, it's just, and much easier to manage than Lovenox bridging to warfarin. So they're still underutilized, and this was true in the warfarin era, and it's still somewhat true in the DOAC era, just of the people who have a CHA2DS2-VASc score that would indicate anticoagulation, somewhere around half actually get anticoagulated. I'm not sure why this is, but it's disappointing, right? There's a lot of strokes, almost 1 million strokes a year happening, that probably a significant proportion of those are unnecessary if they were treated appropriately. But if they are treated appropriately, if all those people are anticoagulated, we could expect to see more bleeding, because somewhere around 1% or less of these people will have a major bleeding complication in any given year, which means we will need reversal agents more often. And in a very strange roundabout way, having more bleeding would actually be a good thing, because it would indicate more people are being appropriately treated and anticoagulated for their stroke risk. It's an old hematology saying, if you have a choice between treating bleeding and thrombosis, treat bleeding, it's easier. That's true. Once the clot is there, it's a lot harder to treat. So the mechanism of action for the DOACs, the factor Xa inhibitors, of course, affect 10, which along with 5 is part of the prothrombinase complex that converts 2 to 2A. And then the direct thrombin inhibitors directly affect 2A. So the two reversal agents, and these two trials ran concomitantly, the Annexa 4 trial and the Reverse AD trial, Charlie Pollock's trial. Both were single cohorts without control groups, because at the time anyway, and these trials started around 2015, 2016, there was no acceptable control, and it was felt unethical to give placebos to patients who were bleeding to death. So both of these, and just you imagine the consent discussion at the bedside. Well, I'm either going to give you sugar, or I'm going to give you an agent that mechanistically we know reverses this anticoagulant that's likely going to cause you to bleed to death. That's kind of hard to get people to consent to. So andexanet alpha, which is the factor approach to reversal for 10As. It's a recombinant modified factor 10A molecule. It's a factor 10 is a serine protease. Remember those from med school? So you replace the serine with alanine, and you cut off the other end of the molecule, which is where the GLA domain, where it complexes with factor 5. So you don't want it cleaving prothrombin to thrombin. You don't want the other end binding factor 5, because that would make it an anticoagulant. So you end up with this inert decoy that still binds to the inhibitor and sweeps it out of the way, so your native factor 10 can function in the clotting cascade and form a clot. The antibody approach, which idarucizumab is just that, a monoclonal antibody that binds the drug, sweeps it out of the system. Both of these drugs work very quickly. Both were based on single cohorts. And we just published the final Annexa 4 cohort in May of this year in Circulation. These drugs, like, it becomes an entire season of your life, 10 years from inception of the idea to actually finishing the trials and getting approval. And of course, the randomized trial of andexanet will be presented at the World Stroke Conference in about 3 days, which will further, we hope, solidify the use of this drug for 10A reversal. We'll talk a little bit about the trial design in today's conference. Obviously, we can't talk about the results. The New England Journal is very picky about what you say before it hits publication, so we wouldn't want to preempt that. Frank, do you want to talk a little bit about the factor 11 inhibitors, since we talked about, maybe the game is about to change again, and just when you solve the problem, there's a different problem, but it may not be a problem.
Yeah, this is I'm Frank Peacock, I'm from Baylor. And this is going to be a game changer again, because we move further up you got the coagulation cascade. We're going to take one arm out instead of two. That's a big deal. So in theory, you can cut your finger and you'll still clot. Where with all the other ones, you cut your finger, you bleed all over. So the safety parameter probability on this one's really high. It's going to be new, it's going to be expensive, and the trial is done and will be reported in like 3 days. So we'll know. But it's going to be a game changer.
Yeah. So factor 11 inhibitors, there is actually, I know that there is a monoclonal antibody reversal agent for factor 11A. I mean, it's a long way from approval, but it does exist. However, it'll probably be rarely used because the bleeding with these drugs is so low. So I think we're back to you actually for.
All right. So I'm at Baylor County Hospital. We don't have two sticks to rub together. We're poor. These drugs have been a fight from the beginning. Generally, me and the neurosurgeon, the trauma surgeons are all on the same side, and the pharmacotherapeutic committee is against us. And it's a dollar thing. If these drugs were $12, there'd be no question. But because they're expensive, we have to fight about it. And so that's where we are. I'm going to show you the guidelines. Before I get onto that, I want to say, look at this poster here. I work with a lot of CME companies. I give talks at cardiology meetings, and they say, oh, we can't show blood and ugly things. And I go, it's an anticoagulation reversal conference. Oh, but we can't show that in the morning to cardiologists. And I say, well, these are emergency docs, and we're talking about stopping this. So I love peer review. Thank you for putting that up there. All right, so these are the reversal guidelines for head Nexa. And they're based on different organizations, and it's important to see that. The very first one up there is the emergency medicine panel. We put it together about 4 years ago. TJ was on it, I was on it, a bunch of folks who do this research. And we came up with it. And Nexa should be the first line drug because it is targeted. All the data we have, which at the time was even less than we have now, show a benefit. So that's emergency medicine point of view. Guideline based, it is not a randomized placebo-controlled trial. ACC, American College of Cardiology, first line with major site or critical bleeding. American College of Gastroenterology could be considered. Now, think about the gastroenterologists. They see GI bleeds. They don't see head bleeds. They don't see retina bleeds. They don't see ruptured aortas. This is, do you have a GI bleed? If you look at the mortality associated with GI bleeds and the DOACs, it's very low. I published a study a few years ago, 45,000 patients on rivaroxaban, 14 died. 8 were intracranial hemorrhage. 6 were GI. So 6 out of 45,000, and that's why they have the most conservative statement of all, is because they have the least risk of all. It's not zero, that's why it could be considered, but it's not mandated. Anticoagulation Forum, if you're on it, you can require it. The American Society, ASH, American Society of Hematology, says stop the bleeding drug. That's really smart. And you can use it. And then ESO at the bottom, if they're on it and they have intracranial hemorrhage. So the societies all think it's reasonable, and the higher the risk of the situation, the more reasonable it becomes. This is for idarucizumab. Now, I run a conference in Utah. We have about 200 emergency docs. And one year I asked them, how many of you have seen a warfarin-related death? 100% raised their hand. I said, how many of you seen a rivaroxaban or a apixaban-related death? And like 3 raised their hand. And I asked about dabigatran, and nobody raised their hand. It's not that it doesn't have risk, but because the penetration of the American market is so small, you're not going to see a lot. But this is the same moniker as before. Emergency medicine physicians think that a targeted reversal agent is the way to go. ACC, American College of Cardiology, first line agent. Gastroenterology, selective use may be appropriate. Anticoagulation Forum, if it is warranted, ASH if they have life-threatening bleeding, and then ESO in adult patients with ICH. So pretty much the same thing as you saw with the Dexnet. Now this is PCC, and so in the United States, 4-factor PCC, Kcentra is what we have, and this becomes a little less clear because at the time of the writing of these guidelines in the last few years, we didn't have any head-to-head data. So emergency physician side comes PCC for DOAC reversal only if you don't have access to a Dexnet or a adairacizumab for their specific agent. ACC, if you don't have access to the first-line agents. Gastroenterologist may be clinically justified. Anticoagulation forum, if adairacizumab is not available or Dexnet's not available, you can use PCC. ASH, life-threatening bleeding as treatment for VTE, and then ESO, PCC is second line. So it's pretty clear that if you have a patient with an identifiable anticoagulation-associated bleed, you should use the appropriate agent for that, and that's the targeted agent, not the more broad reversal. Now, this is the next one, and these are not really built for emergency docs, but these are the definitions of life-threatening bleeding or critical sites. So the BARC definition is a 5-gram drop of hemoglobin. I don't think I've ever seen a 5-gram drop of hemoglobin in the ER because when they're bleeding out, they can bleed to death and their hemoglobin will still be 12 because they bled out and they're dead. And so these are for obviously up on the floor and later. But if there's a lot of bleeding going on, you should consider that and treat them appropriately. ISTH is 2 grams. I have seen 2-gram drops, but those are people who spend a long time in the ER. Critical sites is a lot easier. These tend to be closed spaces where bleeding is going to kill the organ, and the brain is number one. So any site, my feeling on this, and I may be a little more vociferous than most people, but my feeling is if there is any blood in your head at all, you deserve a reversal. Because only one thing can happen, and that is it gets bigger. It's not going to get smaller, and if I don't reverse it, it'll be ugly. Eyeball, spine, airway, pericardium, aorta. I had a guy come in with a bleed into his epiglottis. You've never seen anything more scary than that because what am I going to do, cut him and give him a crike? Because he's already bleeding. So those kind of things you have to be really move quickly on and stop it because once it becomes bad, there's no reversal. And if you need emergency surgery, and it's got to be real surgery, it can't be appendectomy. If you have an appendectomy, I'll give you antibiotics and park you till tomorrow. But if your aorta is dissecting and you have to go to the OR because you've blown out a valve, you got to move, and those people get reversed. This is a bit of a complicated graph, but what it's supposed to show you in the direct 10A inhibitor box in the middle here is that the time of these agents and their reversal is important. So Riva or apixaban is 18 hours or less. So if you're 24 hours out, the bleeding is not due to an anticoagulant, it's due to the hole in the vein or the artery. Edoxaban's a little shorter. I've never seen an edoxaban-related bleed. I know they exist, but it's not a high-use 10A inhibitor in the U.S. And betrixaban is, the reason it was developed was to replace Lovenox. So the idea is we're not going to give you a shot every day for VTE prophylaxis in an inpatient. We'll give you a pill. So it's got a really long half-life, like 24, or like it's present for 24 hours, which is its intended use. I've never seen a betrixaban-related bleed either because it's got really poor market penetration, and it's a hospital drug. Nobody goes home taking betrixaban. I mean, in theory you could, but it's a very tiny thing. Fondaparinol is same story there, 17 to 21 hours. And then thrombin, heparin, unfractionated heparin, we've always had a reversal agent, protamine, and that stuff doesn't stay around long at all. So turn off the drip and you'll be fine in a couple hours. If something bad's happened, we do have a reversal. And warfarin, it's the one drug I wish would go away. It won't. It's still indicated for valves, and as long as we have valves, we're going to be stuck with this because all the studies with the DOACs, they have more bleeding and more strokes, so it's going to be tough to get that reversed. But we have 4-factor PCC, Kcentra. It works immediately. It's excellent. I used to use plasma because it's cheap, and I'm in a county hospital. And I did that until the one time I gave this guy a liter of plasma, and that's what it takes. It was actually the guy with a bleed into his epiglottis, and he immediately went into heart failure. It's like, oh crap, I'm not making things better, I'm making it worse. And so I don't use plasma anymore. It's cheap, but complications are expensive, and I don't want any more of those. So it is the perfect agent for warfarin. So these are the dosing parameters on how to use it. You know, if the VKA's warfarin is all based on what's the INR. The challenge with this, if you're bleeding in the head, my pharmacy and therapeutics dude won't give me the PCC, the Kcentra, until I tell him the INR. And I'm going, the guy's bleeding in the head. It's going to take an hour for me to get that test. And so we've now moved to single-base dosing. And that's based strictly on how dangerous the bleed is. So if it's in the head, they get 1,500. And if it's any place else, they get 1,000. And I don't have to wait for the INR. I think that's a big improvement. DTI, direct thrombin inhibitors, is dabigatran. So when you give the adairacizumab, first-line drug, give them 5 grams. And everybody writes, give them activated charcoal. I think that's insane. It's in the guidelines. It's in the package inserts. And when you see these people 9 hours after they took their pill, what good do you think that is doing? Not a whole ton. So I've never given activated charcoal, although that's off-label to say that. It is on every single label. 10A inhibitors, it's adexanet alpha as the first thing. And they have charcoal listed too, same story there. And then betrixaban, which is the long-acting player. Now you look at this and these seem a little bit contradictory, some of these boxes here. And the reason is this is the ACG guidelines, American College of ACOG of gastroenterology, and these are the guidelines from gynecology. But they choose PCC rather than fresh frozen for warfarin, good. Dabigatran suggests the use of adairacizumab. Rivaroxaban suggests against the use of adexanet alpha. And who are the doctors who are making this recommendation? These are doctors who don't take care of head bleeds. I think that it is fallacious to tell me to not use that drug in intracranial hemorrhage. GI bleeding, vaginal bleeding, that's a different animal. You can stabilize those people. You don't need to use an expensive drug all the time. If they're bleeding out, you should use it. But you do have options otherwise, and they're not necessarily reversal options. They're supportive care options, which actually work. And then the DOACs, they suggest just against PCC administration. So I look at those as being a little bit contradictory, but that's what these things say. And with that, I'm going to turn this back to TJ.
Hi. All right, so talk about the efficacy data on the reversal agents. Wanted to talk about this trial in terms of design that it's reporting out in a few days at World Stroke Conference in Toronto, which, so as I said, early on, there was consensus that we're using there was no consensus on what an active control should be for a trial like this back in 2015. And placebo-controlled struck everyone as unethical in a patient who's, they're selected because they're bleeding to death. So we ended up with the single cohort trials, the Nexafor and for adairacizumab, the reverse AD trials. But once the drug was conditionally approved by the FDA, contingent on doing a randomized trial. So this is the randomized trial, which was initially designed for 450 patients. And after it was launched, additional funding became available in order to create an adaptive trial model that could extend to 900 if certain pre-specified criteria were met at 450. Ultimately, at the interim analysis at 450, the additional patients weren't needed because it met its pre-specified criteria for efficacy. And all that's in the press conference, so I'm not telling you anything, in the press release rather, not telling you anything that would violate the embargo imposed by the New England Journal of Medicine, which it will be in. It's going to be a same-day presentation publication on Thursday. But we can talk about trial design, which is already, of course, in clinicaltrials.gov and has been since the initiation of the trial. So it is a randomized trial between, and it's an open label trial between andexanet and usual care. And I get a lot of questions about why didn't you just randomize with Kcentra? Well, as much as here in the U.S. or in a lot of places in the U.S., everybody thinks, well, Kcentra is what we're using because we have it. That's not true around the world. In fact, there are places, even in the U.S., that use activated PCC, like FIBA, low-dose FIBA instead of Kcentra. There are places that use 3-factor PCC. And around the world, that is also true. Different centers have different usual care, and standardizing that in a fairly rare presentation in order to do a global randomized trial in a reasonable amount of time before we all retire or get too old to do this, required a usual care, which is more generalizable anyway, a usual care arm which can encompass everything. I should say there's a fair amount of places that do nothing because they, and that's the purest approach, right? Until there's randomized data, how can you say that nothing is inferior to something until you've randomized? So that's how we ended up with a usual care control arm in this trial, which 80+% of is expected to be PCC of some formulation in the control group. And narrowing it entirely to ICH. So Anexa-4 encompassed all major bleeding, even though 2/3 of it was ICH. There were GI bleeds there. There were some, there were a couple of cases of epistaxis, hematuria. I think there might have been one pericardial bleed. Where Anexa-I is specifically ICH, and the reasoning for that is just it's so hard to measure hemostatic efficacy outside the brain. I mean, it's hard enough inside the brain, right? I mean, if you had a perfect scenario where you could CAT scan them, give them the drug, and then immediately, and then CAT scan them again at some period thereafter, then the head would be almost perfect. Like you can measure hematoma now, measure it later, and look at the change. The truth is, we all know in reality that hours happen between when the scan gets done and the drug gets in, and things are going on that you're not seeing with your camera. But still, it's better in the head than anywhere else. So the idea is, at least we can be more certain that we're actually measuring an effect in the head as opposed to trying to measure things like hemoglobin drops and GI bleeds, which are dependent on co-infusions of saline because hemoglobin's a concentration. It's fuzzy. It's fuzzy outside the head. It's a little bit fuzzy in the head, but it's really fuzzy to measure hemostatic efficacy outside the head. Thus, an ICH trial to better measure the effect of the drug. So I think we've already talked about this. Oh, the primary endpoint. So the neurologist, if we were speaking at ISC right now, I'd be peppered with questions about why didn't you just use the Rankin scale, the functional scale, which all the stroke trials do. But this isn't, of course, this isn't strictly speaking a stroke trial. It's an ICH trial, which includes traumatic ICH and spontaneous ICH. Maybe not apples and oranges, but Granny Smith versus Red Delicious. It's not the same thing. And also, these endpoints of large changes in NIH stroke scale and hematoma volume as surrogate endpoints, these are fairly well validated for a one-dose drug in the setting of a reversal trial, and coming out of all the precedent in the reversal trials from Kcentra through idarucizumab and the Anexa-4, these were the endpoints used. And also, of course, if you use rescue therapies during that would be a failure of hemostatic efficacy as well. So these are the endpoints. One, hemostatic efficacy, which has precedent all the way back 20 years to the beginning of reversal trials, and then large changes in the NIH stroke scale, which is also a validated measure. Greater, 6 is a big jump, right? That's not a subtle change in their neurologic status at 12 hours. So it had to meet this trial, which will be presented on Thursday. It had to meet both of those endpoints in order to establish efficacy over the control group. And these Anexa-R and A were in non-bleeding patients, and they were done before Anexa-4 even, to establish efficacy prior to doing bleeding trials. Then you can see, and we've seen this play out in Anexa-4, and I'm sure it'll play out in Anexa-I. You get the reduction in anti-10A level very rapidly, and then a bit of a drift up to where you would see on a placebo line at 4 hours. Whereas idarucizumab stayed down longer. However, they're looking at hematoma expansion, ICH. There was the hematoma volumes did not increase between that 4-hour and 12-hour measurement in the Annexa-4 trial. And now we're back to you, Frank.
Excellent. All right. Patient factors, the most important thing. So is bleeding life-threatening? We talked about what the definition of that is, big hemoglobin drop, that sort of thing. Is the site critical? The aorta, the brain. Will they require emergency surgery? The aorta again. Age is always a problem. You can't change it. The older they are, the more likely they are to die. Are they on other meds and comorbidities? And the fragile patients are fragile. You have to make sure that the hemorrhage is likely drug-related. So if they took their drug 24 hours ago, giving them a very expensive drug now is just wasting money. The reversal agents have no value after 24 hours. So that speaks to you need to know when they took their last dose. Because for the rivaroxaban and the apixaban, after 8 hours, you can half the dose you're supposed to give. Before 8 hours, it's a double dose. After 8 hours, and that's a double price. I make a lot of deal out of that because it used to be really expensive. It used to be $4,500 a dose. It actually was $27,000 at one point. It's gone way down, but so it's a lot cheaper now, and it's not as much of an issue as it was. But the double dose, less than 8 hours, a single dose after 8 hours, and less than 18. So you need to know when they take it, and these people bleed in their head, and they come in, I don't have the slightest clue. It's like, well, I assume everybody takes it at dinner, because that's what the package insert says, but in the county hospital, a lot of my patients don't wear underwear. It's unlikely they're following their directions, so it's just the way it is. But this is an important thing. This is Craig Coleman's study. He looked at a huge number of people, 14,000, and looked at outcomes. And this is the people who got Adexanet. That's that dark green color on the far left. You want to be the lowest line of all these, all bleeds, GI bleeds, intracranial hemorrhage. And Adexanet is there on every single one. And you look at, except for critical compartment, there's no bar because there were no patients with critical compartment bleeds. But even the big, 21 out of 14,000 for all combined is not a very big number. So every single case who got Adexanet, now this is a retrospective chart review, but before the trials that are getting done this week, this was one of the best data we had because it's a huge number and you can get the idea that those patients getting Adexanet do better. TJ talked about this a bit. The worst thing that could happen in a head bleed is it gets bigger. My shop, the rule is 60 cc's is considered futile. So if that person on the right came in, they would not get Adexanet because it's not going to change their outcome. Glasgow Coma score less than 8 and intracranial volume, an estimate intracranial hemorrhage volume of greater than 60 cc's. We think that's unretrievably turnable. So you can see you don't want to have an intracranial bleed. The mortality a month is 40%. And so if you get a bleed, you're in big trouble. And that's why the tiniest little bleed, my neurosurgeons are comfortable watching them. I am not. The tiniest little head bleed, I'm pushing for Adexanet if it's one of the 10A inhibitors. So this is the hemostatic effectiveness study, and you can see there Adexanet is favored across the inflection point of the 1 of the odds ratio, and even when it crosses, it's still trended highly there for either overall or intracerebral or intraventricular subgroup analysis. And that was quick. Back to TJ.
So looking at what's happening in our institutions today, I think everybody knows this. It's like everybody has PCC, so there's a lot of use of PCC for DOAC reversal. It would be handy, right, if
it worked?
If it actually worked. If we had one thing that reversed everything. Actually, there's a drug that claims to do that that's still in development. seroparentag, right? But
It's been in development for a decade.
it has been. It's been a long time. We should call them and see what's up with that. But for the meantime, we actually have to think about mechanisms and the question of whether PCC would be expected to work. I mean, there's there's factor 10 in PCC, and we're talking about a factor 10A inhibitor. That sounds intuitive, right? Problem is if you do the stoichiometry, and this, we're not going to do it because it would require using Avogadro's number, and I can see the eyes glazing over when I mention Avogadro's number. But you find that the number of molecules of factor 10 in a standard or even high dose of PCC is an order of magnitude lower than the number of molecules of factor 10A inhibitor, such as apixaban or rivaroxaban at a therapeutic level. So you would expect PCC to work at maybe lower levels, which of course is when you expect people to bleed less, or at least have less involvement of the anticoagulant in the bleeding scenario. But I understand the desire for simplicity. Believe me, when you're in a busy, deep into a busy ER shift with lots of critical care, it'd be nice if you didn't have to think about Avogadro's number. The responses here aren't surprising. That only a third have andexanet, and the use is highly restricted. So it does. I think the problems with the reconstitution for andexanet will go down as the use goes up. Right? Even when we use it, we still use it in the trial. Actually, the trial has been stopped now, but because it's being reported on Thursday. But it did take the pharmacy. It felt like an inordinate amount of time to mix those vials for andexanet and get it to the bedside. And of course, time matters, right? And particularly in ICH, hematoma expansion happens in the first few hours, and most likely, if you get them within those first few hours, you're towards the end of it, right? So you're against the clock to try to stop that hematoma expansion, which, if you've seen it, it's pretty devastating. How many times have you seen the GCS 15? You go do some, you come back and they're heading toward 3, and they'll get there if that hematoma expands. They just are neurologically devastated. It's a disease that deserves our attention. Yeah, I agree with this. There should be predefined, as you mentioned, very large hematomas, 60, the survivability of that's highly unlikely. We can all pull one case out of the many that we've seen where the non-dominant side, they survive, but the vast majority of people with very large hemorrhages, meaningful neurologic recovery is unlikely. And perhaps being a better steward of our resources would tell us to use it in patients with the smaller hematomas before they get that big. And this is back to just what is major bleeding? Life-threatening, or in a place that's confined where it's likely to destroy the organ or the patient. Retroperitoneal, pericardial, and of course always inside the brain. The brain's in a box. There's nowhere for it to go if there's a space-occupying lesion that's getting bigger. So timing a last dose, this is just one paradigm in how you might think about approaching the patient who might require a reversal for major bleeding with a DOAC. But timing is important, and also, of course, renal function within that. So if a patient has normal kidneys and they took it over 24 hours ago, whatever bleeding scenario you're facing, the anticoagulant's probably not part of it. But if they have bad kidneys, the rivaroxaban or apixaban could stick around for days, right? So that's the caveat. It's like, well, what's the renal function? That's the resident says, well, I took it a day, over a day ago, I don't have to worry about it. But their creatinine's 3. Well, actually, you do need to worry about it. Charcoal, really within the first hour at most 2. And it's rare that we see them come in within that very narrow window from last dose. Although I have occasionally seen somebody who fell, got a subdural, but was awake enough to take their evening dose, and then then they came in and it was like, hey, yeah, that might be worth giving charcoal for. Yeah, okay, I think we've covered most of those. Sure, yeah, if you can see the bleeding and can use a tourniquet or direct pressure, that's reasonable. So as far as ways of measuring the anticoagulant, if you can get a rapid heparin assay, most of us don't have. There are a few places in the world that have calibrated assays for apixaban and rivaroxaban where you can actually see their anti-10A level in a reasonable amount of time. I'm thinking one is in Switzerland, but nothing close to me. But you can get a sense of good sense from the heparin assay, right? 0.4 or above, they're anticoagulated. Below 0.4, probably don't have to worry about it. You can get a really rough cut with PT for rivaroxaban, but not for apixaban. It's different drug distributions. But if the PT is elevated with a rivaroxaban patient, then they're anticoagulated, and if it's not, they're probably not. And if you can get dilute thrombin time for dabigatran, if you happen to see one of those, that's a useful marker. The PTT can be a rough cut for dabigatran. Okay, back to the original poll questions. Hopefully, so I should say that in preparation for this question, andexanet will also make it very difficult to heparinize someone. So it has a short half-life. So if you were to give it early on in a bleeding presentation, say for someone who had a aortic dissection and needed an endovascular graft and needed heparinization thereafter, you might want to give andexanet early so that you're not dealing with the difficulty of heparinization during a surgical procedure. And now we can go to that question. Did we just skip over it? There we go. So who would require special consideration? Again, the 75-year-old with a deep hemorrhage and a high stroke risk, the 80-year-old who ruptured aortic aneurysm who might need heparinization during their endovascular repair, the 78-year-old with a traumatic bleed and a recent PE and the cop-out. Okay. I think we can move on. I'm stuck here.
There he goes.
Oh, okay, here we go, new question. All right, how severe, this is, what's major bleeding? I think we've been over this a few times. Is it what would require a reversal agent, which of course the answer is major bleeding, or a critical organ, or life-threatening, or all of the above, and then the questions, the answers below if you haven't been listening.
So you guys are supposed to answer again, I think, aren't you?
Yeah.
So they can tell if you've changed your opinion by sitting through this. And there we go.
There you go, good answer.
All of the above became more populated, which is right.
So yes, it's always good to communicate. For us, we sort of sit in the middle, communicating with the consultants and the pharmacy and as emergency physicians. But yeah, buy-in all across that continuum is really important.
Hey, I want to tell a story.
Sure.
And I'm sure this is something you all have happen. Is I went to my P&T committee and said, I want to get a Dexnet on the formulary. They said, oh no, it's very expensive, we can't do that. I said, well, here's the data. And it's like, okay, we'll do it. And we got it. And I had to sit on a committee and review every one. It was painful. And about a year or two in it, we have another meeting. And they say, hey, what we're going to do is you can't use it unless the neurosurgeons are consulted. And everybody went around the room and said, oh, yay, this is great, blah, blah. And it got to me and I said, I don't give a crap. You all do what you want, but I want to thank the Pharmacy and Therapeutics Committee for decreasing my medical legal risk, because there is no way there's going to be a neurosurgeon in here to consult at 4 a.m. on Christmas. But it'll be your fault. So you're going to get sued and not me. I'll be glad to testify. And they took that away. Because ultimately you're at the bedside. Nobody else is at 4 a.m. And that person's got a head bleed and you don't do something about it. You know whose fault it is? It's yours.
Right.
So this is one of those things you need to fight for your patients. Anyway, that's my story.
So here's the follow-up question on timing. See if we've changed your opinion on timing. Hematoma expansion happens early. And unfortunately, we don't always get the patients immediately after their bleed. So give us an answer on that one.
Yeah, let's do this. I'll tell you what my hospital did. They said 60 minutes. I said, that's absurd.
Yeah.
Yeah, good.
Sooner the better. I love it. Yeah. Let's see,
Alrighty.
Frank.
I guess I got something to do here.
Yeah.
Question number 3. We just did this.
We just did that.
Oh,
Okay,
I'm
that's
pushing the
you.
wrong button. There we go.
You're doing the row. This is rows.
All right, this is rows. 7. Oh, we got to do rows first. 78-year-old lady receiving apixaban for thromboembolism prophylaxis presents emergency department with low-impact head injury and a subdural hemorrhage. How will you now treat her? Supportive, charcoal, vitamin K, 4-factor, adexanet, daracizumab, I don't know. The problem is there's more than one right answer here. And the reason is one always counts. Supportive measures are always important, and you should do them. And this, is, I think, is Rose. And that's her subdural. And that's enormous. And I'd have to talk to my radiologist about, does that hit the 60 cc threshold? Because a Glasgow Coma score of 9 and a hemorrhage greater than 60 Cs in my department does not get reversed because of the cost does not justify the outcome. And the outcome is this lady is going to be pronounced dead in 3 days, which is a terrible thing, but I can't do anything about it. First rule of emergency medicine is patients die, and second rule is you can't change rule number 1. This is how it's going to be. So, rethink your answer. All right, did we answer that again?
I think we did.
What? I didn't get to read it. You guys were too fast. There we go. Number 5, adexanet alpha. Good. And some people weren't supportive, which is fair. I can't advance.
Yeah, it's not. Well, not advanced. Oh.
Somewhere we have a
We're back
summary
at the
slide
beginning.
that says that the hematoma expansive is quick, usually occurs in the first few hours after you identify the bleed. Timely administration of the appropriate anticoagulant reversal agent will achieve rapid hemostasis and is likely to have a benefit. Specific reversal agents are available and are indicated by most of the societies as first-line treatment, with PCCs as second-line treatment if you don't have first-line treatment. And there's still lots of places in the United States that don't have direct reversal agents. And, lots of small hospitals in the country and urgent cares and that sort of thing where they can do a CAT scan. Freestanding emergency departments may not have it. So plan B is Kcentra. Real-world data suggests that adexanet alpha is superior, and we'll have the prospective trial in 3 days and be able to close this box on October 12th.
I see a question popped up here. Can you use Endexa for someone who already got 4-factor PCC for a significant ICH?
That's
it's
a
an interesting
great
question.
question.
Those patients would have been excluded from the trial, so we're stuck with just sort of mechanistically speaking, what would the thrombotic risk be? I would expect to be kind of high, right? So you just overloaded them with 2, 7, 9, and 10, which is the 4 factors in a 4-factor PCC, and then you're going to give a recombinant 10 on top of that. Realistically, most of the time we get one bite at the apple, right, if you're going to stop a hematoma expansion. So you have time to give one drug. If people say, well, if the bleeding continues, then you can reassess. If the bleeding continues, the cat's out of the bag and it's too late to do anything. I think the question, if you're asking, would I give, if somebody had already gotten PCC, let's say maybe they got it at another facility and
Yeah, they were
transferred
transferred from the freestanding ER down the street.
Yeah,
And an hour later in my department, I'm going like, you're still bleeding.
Yeah, I mean, if it been inside the head, if still bleeding means probably dead at that point. If it's bleeding somewhere else, and maybe. I'm not going to be able to give you a definitive answer. It kind of would depend on the patient, but most likely, I would be very worried about giving andexanet on top of PCC.
Your worry would be theoretical concern for thrombosis versus an immediate concern for death. So
Right.
I would take and I'm more aggressive, obviously, and we have no data. We're in a data-free zone.
Yeah.
But I would absolutely give the patient the Andexxa if an hour into it, the four-factor BC was not working. Because as you said, you have one bite of the apple.
Right.
Yeah, one bite of the apple will save this dude's life. And
Sure.
if I don't do anything and he's obviously bleeding, getting worse, that means your first stuff didn't work. It's time for Plan B.
No, I think that's
and
true.
you may clot. I mean, that's
Right.
all the studies have a measurable clot risk when you do this. But that person who was on an anticoagulation had a huge clot risk before this started, and you can't go back in history. So they will have a clot risk. And when you turn off their drug, it will seem larger. You didn't make it bigger. It's the same risk they had before they got put on the anticoagulant. And your only hope is to stop the bleeding when they're bleeding badly. If they're not bleeding badly, you don't do anything. Wait, the drug will wear off.
An interesting question here about an emergency cardiac or aortic surgery case. Patient with onapixaban, so they're reversed with andexanet, and they have post-op bleeding. What would you consider the indications for redosing? Again, we're probably in a data-free zone. And there is it's designed, I don't think it's actually enrolled, but a surgical trial to answer some of these questions. But in general, we would expect that you would use the infusion of andexanet just intuitively would be the duration of the surgery. So hopefully you wouldn't have, but you could still have post-op bleeding, right? Because we know you're going to return, within a couple hours, you're going to return to that placebo curve. So theoretically, you could get some post-op bleeding from that. And again, it's a data-free zone. If the bleeding's life-threatening and the andexanet's worn off and the 10A inhibitor has not, I don't see why it would be unreasonable to give another dose.
The key is the timing of the andexanet. So if you're at the 24-hour window, they're bleeding because the surgeon didn't put enough stitches in.
Right.
If they're at the 8-hour window, because things went through quick, they still have active drug on board, and andexanet wears off. I mean, and you may have to give a redose if all the timing clocks have to line up right to do it. But you can come up with a scenario where that happens.
Do you want to answer this? I don't use a lot of TAG, but someone's asking about the utility of TAG and deciding on the use of reversal agents.
TAG is great. I'm doing a big trial on it right now. Here's the challenge with TAG, is it takes me a good hour to get it. And if you're bleeding to death, I'm sitting there going like, you took your what is it? You took your rivaroxaban 4 hours ago? I'm not waiting an hour. And so I wish TAG was quicker. It just isn't.
Yeah. And this other question is about preparation and administration. So currently it takes an hour. It takes an hour, and that's unfortunate because that's an hour during which hematoma expansion is likely occurring, right? It takes an hour to prepare andexanet at our facility. Now, do I hope that, and presuming, well, we know from the press release that it was stopped for efficacy, right? So if we have a net clinical benefit shown in a randomized trial, broader use, I can foresee a day, so I have a dream that it'll become like TPA for ischemic stroke, right? You'll have a door to needle time for andexanet in the setting of factor 10A associated ICH, and we'll all get better and faster at getting it in the patients.
We have a live question.
Yes.
I have two quick questions.
Sure.
One's simple. What is the cost of a single dose of andexanet?
Sure. So right now it's $12,000 for the low dose, which is about 85% of the cases. So.
And the second is, at least maybe I'm the only one who's confused. It was not clear to me whether the criteria for using it was a major bleed or even a very small bleed, based on Dr. Peacock's assessment that small bleeds, if you ignore them and say, well, I won't treat it because it's not big, then an hour later, it does meet the criteria.
So a major bleed is all those hemoglobin drops, which I don't have much.
Or bleeding into a critical organ like the brain.
I was getting there.
Okay.
So it's a major bleed is a volume or a space. So any bleed in your head is a major bleed. Any bleed in your eyeball is a major bleed, or your spinal cord. A bleed in your buttock can wait for a long time. And so it's either a lot of blood, like a retroperitoneal hematoma, I can't compress it, I can't get at it, and you're going to die. So a lot of blood there would be a problem. A small amount of blood in the retroperitoneum, I'm not sure. But anything in a closed space is going to be a problem. And time is cells. You've got minutes.
So the location is probably much more important than the volume of blood.
Absolutely, for the critical sites.
Yeah.
And that's why the mortality of a head bleed is something like 40 or 50%. The mortality of a GI bleed is much lower.
Thanks.
Yes, what is the cost? And number two, how long does it take to work when you have a small, so to say, cranial bleed?
So I'll take a whack and then let TJ too. The onset of these reversal agents is 2 or 3 minutes. They're very fast. The cost, and TJ said this a minute ago, is $12,000. That's very institution dependent because there's a lot of government buyback programs available. Depends on what your hospital, how it fits in that program. I can get it for like $4,500, but we have a million programs that we, because we're a county hospital, that we can go for. And a for-profit hospital wouldn't have access at that. So it depends somewhat of your situation.
Thank you, Doctor. It was a very nice presentation. You spoke recently about the ischemic stroke, and I remember we have some patients taking dabigatran. We sometimes use idarucizumab and then TPI. Can this be done with Andexa?
Can it be done? Yeah, has it been done? I don't think there have been any case reports yet. We actually designed a protocol that we have not managed to actually push forward to trial, but reversal of anticoagulation for thrombolysis. I mean, it's a valid question. There's some case series for idarucizumab and dabigatran reversal, and then these are for patients who arrive with an ischemia. They've stroked through their anticoagulant, which actually does happen a fair amount of time. So you can't obviously give we believe that you can't give thrombolysis in the setting of an anticoagulated patient, right? So why not reverse the anticoagulant and then thrombolyze them to try to break down the clot wherever it is in their brain? That's the idea. And there's a lot more evidence for that for dabigatran and its reversal agent than there is for andexanet. But it's a very interesting idea.
We don't know.
Well, thank you all so much for coming this morning. I really appreciate it. And if you have any questions, just feel free to contact me or Frank. Our emails, I'll give them to you if you come up. But it was good meeting with you all this morning. Thank you to PeerView and thank you to AstraZeneca for supporting this activity.
Thank you.